Okay, let me explain this question. Regarding systematic review of evidence for surgical treatment of glaucoma, which one of the following statements is most likely to be true? Viscocanalostomy has an equivalent pressure effect or pressure lowering effect to trabeculectomy. This is not true, as the results or the systematic review that compare between the viscocanalostomy and the trabeculectomy showed that the trabeculectomy showed more reduction. More reduction of intraocular pressure occurs with trabeculectomy, but unfortunately it comes with a cost, as trabeculectomy tend to cause more cataract and more infection. The randomized controlled trials of tube valve surgery versus trabeculectomy alone showed higher rates of adverse event following trabeculectomy. This is the correct answer. So these trials that compare the tube versus trabeculectomy showed that the side effects after trabeculectomy, such as hypotony and infection, are more with trabeculectomy than with valve. However, both of them will show the same reduction of intraocular pressure, and both of them will show the same reduction in the visual field changes. So the C and D here is the wrong answer. No here is wrong, and no here is wrong. Because there is a clear pressure lowering effect from the use of 5-fluorouracil in case of trabeculectomy, but this comes with a cost as well, as it will cause persistent epithelial defects, it can cause bleb leakage, it can cause infection, but it can decrease the intraocular pressure. And the same thing goes with the beta irradiation. Beta irradiation, when it is used with the trabeculectomy, it can cause much lower effect, but again, it comes with a cost, as it causes cataract. So to review what we have said in the clinical trials lecture, according to the trabeculectomy versus canalostomy systemic review, the trabeculectomy will show more reduction of the intraocular pressure than the viscocanalostomy, but the side effects or the adverse events of the trabeculectomy are more than the viscocanalostomy. The trabeculectomy versus tube study showed that there is no difference or no significant difference in the intraocular pressure reduction between the tube or the trabeculectomy, but the complications rate or the side effects are higher in case of trabeculectomy than in case of tube. So this was the right answer. This is the answer which is here, that the randomized clinical trial of the tube valve surgery versus trabeculectomy show higher rate of adverse events followed the trabeculectomy. So this is the correct answer. For the fluorouracil filtering surgery, it showed that the IOP reduction with the use of 5-fluorouracil is about 75% compared to only 50% when we are not using the 5-fluorouracil. But actually, we don't use it on routine basis because it has higher incidence of complications, can cause bleb leakage, bleb rupture, persistent epithelial defect, infection, and endophthalmitis. And finally, the trabeculectomy versus trabeculectomy and the beta irradiation systematic review showed that although the trabeculectomy show higher reduction of the intraocular pressure, it show lower IOP, but it show more incidence of cataract. And this is the same reason why the beta irradiation is no longer used with the pterygium surgery, although this was the routine practice like about 40 years ago, for example. This is because the beta irradiation showed to cause the patient cataract. Okay, another questions about clinical trials. Okay, so regarding the evidence of medical treatment of glaucoma, which one of the following statements is most likely to be true? According to the clinical evidence, the timolol, which is a beta blocker, is stronger than the topical carbonic anhydrase inhibitors such as brinzolamide and dorzolamide. So brinzolamide and dorzolamide are weak, specifically the topical, have a weaker effect or weaker lowering effect on the intraocular pressure. So both A and B are not true. Latanoprost has a stronger pressure lowering effect than bimatoprost. This is not true again. The bimatoprost will be as equal as latanoprost, or sometimes some people say that bimatoprost is a little bit stronger. Latanoprost is better tolerated than the bimatoprost. This is the correct answer. So as the latanoprost is associated with lower incidence of conjunctival hyperemia than the use of bimatoprost or even the travoprost for treatment of ocular hypertension or glaucoma. So this will be if you are giving a patient bimatoprost and you can find he is not tolerating it, like he is complaining from conjunctival hyperemia, which is very bothersome for the patient, then you can switch it to the latanoprost. So as we mentioned, according to the evidence regarding medical treatment of glaucoma, prostaglandins they show that to be are now are considered the first choice drug unless or other if they are not contraindicated, like bimatoprost, latanoprost, travoprost, and the latanoprost will be the most well tolerated. Beta, then followed by the standard first choice drug like 20 years ago, which was the beta blockers. So these are stronger. Then followed by the alpha 2 agonist and the parasympathomimetics, and the weakest will be the carbonic anhydrase inhibitors.